Yeah, so that's actually the problem that we are addressing right now. The patient doesn't get the care he or she needs. And the reason is that most transplant centers, if not all, in this country and anywhere else, refuse to do kidney transplants in patients who exceed a certain degree of obesity. So if you do a registry analysis, so you look at the numbers of patients that have been transplanted, and you use statistical methods to identify risk factors, you will actually come to the conclusion that if you isolate obesity, it's not a risk factor for bad outcome. The issue is that obese patients in general, but not always, have additional risk factors such as cardiovascular disease, diabetes, high blood pressure, and those risk factors are well known and well described to reduce the chances of having a real good outcome. And so now the difficulty is, how do you select for the right patients without essentially discriminating for obesity? And that's what we want to address. We want to really show that based on our experience, obesity should not be a reason for not doing the transplant. What does really differentiate an obese patient from a lean patient? And it's essentially the risk of wound infection. So again, taking everything equal, the risk of wound infection in an obese patient is much, much higher than in a lean person. Now, for some reason, and that's somewhat surprising, for some reason the wound infection has down the road effects that lead to an inferior outcome, so less good kidney survival and less good patient survival actually. Ideally, you would do this surgery minimal invasive. Now, minimal invasive means laparoscopically, and that means usually we lose lots of our dexterity because we operate essentially with chopsticks. And doing a kidney transplant laparoscopically is certainly feasible in expert hands, but it's probably not very safe because you are very limited in what you can do. And so where the robotics come into play is just by enhancing the dexterity of the surgeon doing minimal invasive surgery, because the robot has like 2 mini hands inside the body. And so we can essentially do anything we would do open, we can do with the robot. I would even go to the point we can do more than we would do open. Let's take an example. I'm right-handed and I sew with my right hand, and sometimes it would be convenient to sew with your left hand, but open I'm not very skilled in doing that with my left hand. However, when I operate on the robot, I don't even think whether I use my right or my left hand. I'm equally skilled in doing complex tasks. One issue that an obese patient has is the larger body mass, and there are, as sophisticated as we are built, there are still some mechanics in the way we function, and the amount of functional kidney you need is in relationship with the amount of body you have. So clearly, if you have a very large body, putting in, for example, a kidney from a little tiny lady would be an enormous stress on that kidney and would lead to something that we call hyperfiltration, so where a kidney works beyond what it was actually built for. And so yes, so that's actually one of the limitations for the kidney transplants in very heavy patients is we do have to select the donor, and we have to, I think there's a trend that we have to use the better kidneys for obese patients. The important aspect is that you cannot be cavalier about. It's not about just putting in a kidney and then bye-bye. So we have to work very intensively with those patients. And the message we want to bring across and that we investigate is getting the kidney transplant early really matters. But then you have to work on the weight loss. And of course that only works for those patients who have a living donor, because then we really should not delay the transplant waiting for the weight loss. So do the kidney transplant, then do intensive weight loss management. For those who are not lucky enough to have a living donor, of course we work intensively with the patients, with the entire armamentarium that we have, to make them lose weight while they're on the wait list. Now the interesting thing is we have just published our intermediate data on a small group of 20 and 20 patients in each arm. The weight loss was not dramatically different, if at all, between the groups. What was very different is the amount of lean mass, so regaining muscle, and most importantly, social reintegration. So the patients who were in the lifestyle coaching program almost invariably returned to work gained again insurance and became independent, whereas the control arm, with very few exceptions, nobody returned to work. What I have to say is that I've rarely had a patient group that is so rewarding to work with. They come, they hug you, you transform their lives because they feel guilty. They feel like they deceived everybody around them, and then they were told, well, you are essentially too fat to be transplanted. I mean, that's how they perceive it, and that's essentially what we tell them. And now they got this kind of last chance, and they hold on to it. And so I think it's extremely rewarding to work with this patient population.